Dr. Amy Kritzer is the clinical chief of the Division of Genetics and Genomics at Boston Children's Hospital and the director of the Metabolism Clinical Program. Her clinical work is focused on the care of children and adults with rare metabolic disorders. She also serves as the genetics physician lead for quality improvement in her division. And in this role, she creates and implements patient care initiatives designed to improve patient safety and patient and family experience. Her work is dedicated to addressing the psychosocial needs of patients with rare diseases with a focus on improving quality of their lives. Amy Kritzer.
I feel like I have a hard act to follow. Listening to all those very generous people, and it's really wonderful to be here. And I will say I am very fortunate because my associate chief is Dr. Mira Irons, and so the legacy of Smith-Lemli-Opitz, caring for kids with Smith-Lemli-Opitz syndrome in our division is very, very strong. I am really grateful to get to be here with you today and to welcome everybody here to Boston and to welcome everybody here to the conference. It happened. I consider myself really lucky. I happened to be in the right place at the right time. And right out of fellowship, I had a physician leaving who had been caring for the patients who had Smith-Lemli-Opitz syndrome, and I went, mine. I want all of those patients. And so I really felt very fortunate to inherit this incredible panel of patients and their families who had been cared for, first by Dr. Irons, then by Dr. Nealon, and now I got to be involved in their care as well. And I found that these kids were just so special, and their families were as well, and I really enjoyed that experience. So through today's talk, I'm really hoping to give you a couple of tools that might resonate with you. Some you may be familiar with, some you may like, some you may hate, some you may use, but really to just give you some different ways to think about how you engage with healthcare, with other teams of folks who care for and work with your families, and ways to make sure that people understand who your child is and what is important to you. And then we'll talk a little bit about transitions of care, although that could be a 5-hour talk in and of itself with a lot of holes, because we all know that there's a lot of challenges there. And then also we'll talk a little bit about meaning making in healthcare, which refers to the process by which we are able to interpret and find the positive experiences and integrate those into your narrative and into your coping. So this graph actually comes from an unpublished study that we did several years ago on the experience of living with Smith-Lemli-Opitz and meaning making. It was actually a student project from a genetic counselor who was working with me. And what we found, we'll go over a little bit, but about 20% of children and youth in the United States, or about 14 million kids, have a special healthcare need. And so as known to this group, having children with special healthcare needs has a myriad of providers. You have a lot of services. There's a lot you're doing to improve, maintain health and functioning and quality of life. And that leads to considerable strain. So what we did when we looked at this was we actually asked families, and there may be people in this room who answered this survey, so thank you if you did. But it was a relatively small study, and what we did is we looked at using by severity score, did people identify significant sources of strain, either in relationships, physical strain, financial strain. And I think obviously to everyone in this room, it's clear that there's a lot that you have to do. And there was considerable strain for everyone. And while this made for a pretty graph by defining it by severity score, we also know that the severity score in Smith-Lemli-Opitz is not perfect because it really only accounts for the physical differences and does not take into account all of the functional, developmental, cognitive, and all of the things that often many people feel actually impact their life more than some of the physical or anatomic differences. But it made for a nice graph to do it by severity score. But about 100% of folks had said that they had some psychosocial or mental strain. about 89% kind of across the board identified with all of these types of strain. And so we know that, parenting a child with medical or developmental complexity is complicated and very difficult. So if I could, I would gift you all a personal care assistant who would do everything for you. They would manage your appointments. Wouldn't that be amazing? So my family knows that if I ever won Powerball, my dream is to start a care coordination organization. I play when it gets really, really high because I feel like then I'd have enough money to do it. But I don't think that's ever going to happen, sorry. But in my fantasy world, that's what I would do. But in lieu of being able to do that, I think what I want to give you is some frameworks in healthcare. Sure. What I want to do is to give you some different frameworks in healthcare that might help you think about how you engage with healthcare, how you advocate for your child, and how you basically make sure that people see the joy and the accomplishment of your children as well. So we'll talk about what matters to you, which is a framework that's come in the last about 15 years into healthcare. Care coordination. We'll talk a little bit about care mapping, some transitions of care, and then lastly we'll talk about meaning making. So we'll use some common life experiences to kind of set the stage for some of this. So to explore these. So you can imagine. You get up, you rush to get your kid out of you get dressed, you get out of the house, you drive to the office, you get from the parking lot, which may be close to the hospital, may not. You finally get into the office, you wait, and then comes the dreaded heightened wait, and now everybody's upset and crying. And then you go into the doctor's office, and maybe you wait some more. And then maybe the doctor comes in, and you're trying to remember your list of questions, you're trying to listen to what they're saying. And if you're lucky, maybe you have a physician who you think really knows your child. If you're unlucky, you're sitting there trying to explain what Smith-Lemli-Opitz is and why you're there to see them. And it, can be a very difficult experience. And, your child is probably giving hugs and kisses the whole visit. And if your doctor is like me, likes those hugs and kisses, and some other doctors, might not. And all this time, you're really trying to focus. You're trying to remember what's being said. You're trying to think about that next question. You're trying to remember everything that's being given to you in that visit. And now when it's time to leave, you're exhausted and everyone needs a nap. And you get in the car and you kind of go home and you try to remember what was said. Was there a medication dose change? Was there a new medicine they wanted to try? What were the side effects? And it's a lot of information to really try to wrap your head around. And so, when you think about, coming into healthcare, it's just, there's so many questions you have, and you're really trying to be the advocate for your child. So what matters to you, I think is a really, really beautiful and elegant, simple framework. And it is probably one of my favorite in healthcare because it is individualized and it really focuses on your family's experience, prior experiences you may have had in healthcare that really have given you perspective. And it really allows you to think about including your own cultural or social experiences, things that are important to you. And it's really a model of shared decision making. But it's shared decision making that really puts your experience and what's important to you at the forefront of that discussion. And so it's really simple. The principle is basically ask what matters, listen to what matters, and then do what matters. And so this is a way to help healthcare providers understand what is important to you and your child or your family. And it really leads to better partnerships because it allows the provider to really think about what's feasible for you, what types of things that might be able to be done, or what things that really aren't going to work for your family. And if you think about, if I ask a family, I need to make a bunch of referrals for you. What matters to you? Well, one family might tell me, I come from a really far distance. So what matters to me is that we have as many visits as possible on the same day, because I'm not making this trip back and forth. Another family might tell me, well, my child gets very stressed out at doctor's visits. So what matters to me is that we actually have as few visits as possible, or not more than a certain number in a time frame. Another family might tell me, what matters to me is that I see the person you think is the best person for me to see. I see the doctor that you think has expertise in Smith-Lemli-Opitz. And another family might say, what matters to me is I never step foot in these clinics ever, and I want everything by telehealth, if at all possible. So can you help me figure out which visits can be telehealth and which visits can't? And the same applies to medications. Sometimes families come in and say, you know, I only give the medicines half of the time. And if I say, well, what matters to you when it comes to giving medications? Some might say, you know, I have to give these by mouth, and it's really, really hard for me, so I want to give them as few times a day. So which medicines could be given once a day? And if they can't be, then I know I need to really tell the family why this has to be a twice-a-day medication, because I understand what matters to them. I'm asking them to go against something that they want. Some families might say, I want the smallest volume of medicine possible, even if I have to give it 5 times a day. So when you ask what matters to me, when you ask what matters to them, you actually are making medical care decisions that fit with what they want. And therefore, people are going to be more likely to be able to actually do the things that they want to do for their child, because you've put it in a way that they can do it for their child. And so what matters to me is just this really wonderful way of thinking about family experience. And it's become a movement in quality improvement work where instead of just saying, how is your experience, it really is kind of, how do I shape your experience so that it's better? So I made this. It's my poor attempt at art. You know, when you think about calendars, so everyone has their own way of tracking things. Some people have a phone calendar, some people have a good old paper calendar, and you sit there and you write in all the things you have to do. You've got speech this day, OT, you've got different doctor's visits, and sometimes when you visually represent it, wow, it's a lot. And then maybe you throw some fun things in there like swim, but then you realize that you also got to go to CVS, and CVS is closed between 1:30 and 2 because they have lunch, and so now you got to like work your day around CVS timing. And so it's just a lot that you have to do in any given time, and it's a lot to keep track of. And so I tried very best to have nice handwriting here, but you know, many times when you're busy, you're scrawling things, and sometimes you're not even sure what you wrote. And so we know that in integrated care, so this is another model that looks at coordinated care across professionals, across facilities, and support systems. And so it's continuous between visits. So when you think about having an individual visit, well, that's just one kind of dot in a moment in time, and you have all of this other care. So the model of integrated care really thinks about the time between visits, that it's tailored to the patient and family experience, and that it also takes into account the fact that healthcare is only one of many, many things that people have to do in their time frame. So pediatric coordinated care or integrated care really links children and their families to appropriate services, not just through healthcare, but also through other support organizations. And so patients with Smith-Lemli-Opitz syndrome, obviously many have developmental differences and benefit from supportive services such as PT or OT or speech, feeding therapy. And in order to engage successfully in integrated care, you really need to understand how all of those come into play and all of the different players that are happening at the same time, which can include, you know, healthcare providers, it can include school, therapeutic providers, childcare, early intervention, nutrition, social, emotional, behavioral health supports, community pediatricians or partnerships, and social services partnerships. And all of these together come together to hopefully improve the quality of care for children and youth with special health care needs. So what are the functions of care coordination? It's a great concept. It's just really, really hard in practice. So in 2014, the American Academy of Pediatrics put out a policy statement that defined it as, and this is going to be long, a patient and family-oriented, assessment-driven, team-based activity designed to meet the needs of children and youth while enhancing the caregiver capacities of families. So what the function of care coordination, and there are a lot of definitions, at its core, it's a system to try to develop a plan of care that actually uses health technology well and supports transitions of care. So whether that's transitions of care between healthcare providers, between school and healthcare, between different healthcare institutions. There are a lot of different places and points in time that require care coordination. And so when you look at the qualities of what actually makes good care coordination, and there have been a lot of studies to look at this, what you find is there are several factors. They have to be patient and family centered. So they have to actually think about how the family functions, and they link patients and families with accessible care. They have to be proactive, planned, and comprehensive. And I think that that's really the key. They have to think ahead. So much of what we do in medicine is reactive. We get new information, we start a new medication. But when you start to be able to think proactively about what's going to have to happen, you really actually can design health plans that have a much more thoughtful example. And so, that could be things even like making sure that you have enough medication prior to a holiday weekend where shipping delays may happen, or a family who might be traveling, reminding families to say, do you have any travel coming up? Do you have enough medication on hand? Do you have enough formula? Do we need to order early? Do you need a vacation override? What else does the physician have to help you with to make that happen? Care coordination really addresses the interrelated medical, developmental, behavioral items that actually link us together. And so it establishes relationships between patients and families, between, communication between different professionals, partners, and it uses expectations and defines them and defines how communication will happen. So sometimes we say, we'll get back to you. Well, what does that mean? Are you going to call me? Is that a portal message? What's the best way to communicate with you? And care coordination acknowledges that there are not, that there are a lot of supports that are unique to families, and therefore we have to take that into account. So when we think about the benefits of care coordination, there are some high-level ones. So improved child outcome. So when care is coordinated, kids do better. Kids are less likely to be missing doses of medication. They're less likely to not have follow-up with providers that they might need to see. They might have better times getting their labs because the labs are coordinated, so families are going to the lab once instead of after 5 different visits. And they show improved satisfaction. So families report significant improved satisfaction with health services, as well as improved psychological benefits to patient and family. And there are social benefits, such as improved quality of life, because you actually can attend work more, or you can attend school more. You're pulling your child out of school less, which most people, that's a nice thing because it doesn't disrupt that routine. And we know that for kids with Smith-Lemli-Opitz syndrome, they love their routines. And so disrupting routine is in and of itself a challenging situation. There are also improved family well-being because now the family has less stress because they have some supports coming to them that help them navigate the complex world of medicine and social support services. And parents report feeling really empowered with care coordination because they feel like they actually know exactly what needs to be done, and they have a tool to do it, and they know what to do in every situation. And that allows them to feel like, I'm not forgetting anything. And that feeling of I'm forgetting something is really strong for most people. And I will say, even as a physician, I feel that too. What am I forgetting? What did I forget to do for that patient today? And it's very interesting that they actually report that not just families benefit from good care coordination, but healthcare providers do too. That with care coordination, physicians who utilize care coordination actually report less stress because they're not worried about the things they've forgotten to do for their patients. That they feel that there's reduced hospital visits, there's reduced unnecessary things being done because it was coordinated right the first time. And that they find that we're not duplicating efforts, we're not duplicating resources. So by understanding who within the healthcare team is going to be doing this, you don't have 5 different teams kind of calling you and trying to figure out what you need. And among families with kids with special healthcare needs, about 72% of them reported getting some help with care coordination. And sometimes care coordination might happen without you seeing it. I think that that's good, but it's probably better if you know what's happening behind the scenes for your child. And sometimes it's dedicated staff who might be doing it. Sometimes it might be a trusted partner who steps in to assist. Some families say, can I bring an extra person with me? My sister, she's really good at this. She's in healthcare. She really wants to step in to help us understand and ask the right questions. And absolutely, it's great to bring extra people with you to visits that can help you navigate and remember things. So additionally, other benefits of care coordination is that it goes beyond the medical management piece. It is healthcare providers, who could be physicians, nurses, allied health professionals, reported that care coordination resulted in more productive clinic visits. It actually reduced the amount of time you spent in clinic and the number of clinic visits in total. And it reduced the duplication of tests, assessments, follow-up recommendations. And it had it provided better connections between the school and the home and other people who worked in them. And when they've looked at care coordination for children with neurodevelopmental disabilities, and this was a paper that used a particular tool called the Care Coordination Measurement Tool, what they found was that about 65% of the time of care coordination was actually spent on referrals and making sure visits were getting scheduled. So it wasn't doing the things that didn't have to happen anyway. It was 10% might have gone to helping families navigate or empowering families. Maybe 10% was spent in skill development, 10% was maybe spent on looking at other developmental needs, but the majority of care coordination was actually all around referrals and communication, around having to get those visits done. So it was work that was going to happen. It just shifted who was going to be responsible for doing that work. So, as everyone in this room knows, caregivers become the managers of their children's healthcare. And that often becomes a lot. And so when we think about, what tools can we use to help you manage better, I want to introduce a couple of those that I think hopefully are logical and make sense, and some of which you probably use because they're things that a lot of teams do use. So when you think about this, I often think about what information do you need to collect? So who? Who is this doctor? What's their name? Who are you seeing? What is their specialty? You have a lot of names, and a lot of families have a hard time remembering kind of who does what. So who are they? What do they do? Where are they located? Where is your appointment? Is it at a clinic, a satellite? Is it telehealth? When are you seeing them? And why? And I think the why is actually really important. Why do you see this doctor? What do they provide for your child? What are they the ones responsible for? And then I added do. So what do they do for me? Do they prescribe a particular medication? Do they write the letter that I need for my child's school? So when you kind of can track who does what, and where, when, why, when, who, what, where, when, why, do. you can start to say, okay, who do I call when I have questions? And that's what I hear a lot from folks is my child has 7 doctors, and I don't know who to call when I have a problem. So who do I call when my child has a seizure? Who do I call when I don't know who to call? Who do I call when the G-tube is malfunctioning? Who is responsible for all of these many, many aspects of my child's care? And so I find that, when you can have a grid that outlines it for you, you can also hand it to someone else and say, I don't know who to call. Here's everybody, you tell me. So let's visualize this in a care coordination tool. And this is a tool that's used by, that I modified from what is used by our complex care service at Boston Children's Hospital. But essentially, it's a kind of a way to just write it all in one place. So who, doctor's name, what is their specialty, where are they located, when am I going to see them, why do I see them, and what are they doing for me? And then it also asks you to involve the other providers, so it's also in one place. Who are my social school intervention team? What's their role? So, is this Laura and she is the OT? Is this John and he is the speech therapist? Is this the special education team member? Who do I call if I have questions and I don't feel like my child is getting what they need? And then it also has any community resources that you have. And community resources can be very powerful and very important, often very variable by state. And so knowing if there are community resources that you can tap into locally, either for care coordination or for other support services can be really helpful. And then this is an action grid that I also really like. This is designed by the Integrated Care Service at Boston Children's. And the Integrated Care Program at Children's is really basically creates and validates processes and tools. So they don't, they get a lot of calls from families saying, great, will you integrate my care and do my care coordination? But they really are around designing tools that we can use to be helpful. And so this is really a grid that looks at what is happening in an individual visit and what can you do to get the most out of your visit. So when you walk away, you have a written copy of what happened in that day. And so the goal might be to change the medication dose. The action might be to go get your blood drawn. Who's responsible for that action? And I think this is a really important one. It reminds everybody, who's going to be doing this? Is it going to be the physician? Is it going to be a different physician on your child's care team? Is it going to be you? And so here it might be the family needs to schedule a lab draw. When do we expect that to happen? Within the next 2 weeks. And then contingency, what if it doesn't happen? So let's say you can't get to the lab, you can't get your cholesterol level checked. What's the plan then? So in this case might be, we're going to continue the current dose until we get that lab checked. So I really like this grid because it really defines, what we all are doing at the end of a visit and then who's going to do it. So I call this homework in my clinic. So I will say to a family, okay, I'm going to do a recap and I'm going to say what my homework is and I'm going to say what your homework. So my homework might be to order your labs. My homework might be to write that letter for school that the school needs. My homework might be to make a referral. And then your homework might be to schedule a lab visit. And so then when we walk out of the room, after all this talking and back and forth, we actually have that kind of concise, here's the plan. And then you can put that on an action grid, and therefore you have a written copy of that. And this can be filled out during a visit. This could be filled out after a visit by the provider, and then sent through as a message. We're playing with whether we can make this into a template for after-visit summaries. But it really kind of helps you say, okay, I know exactly what I need to do. I know what I expect from my doctor. So if they're not doing it, I know when I can start. It says when. It told me I'm supposed to expect that letter in a week. So if I don't get it in a week, I can start sending those portal messages reminding people they didn't send it. So I really like this quote. Advocating for your child. Promise me you'll always remember you're braver than you believe, stronger than you seem, and smarter than you think, says Christopher Robin to Winnie the Pooh. And I think that it's, as we've heard a lot about in this conference, absolutely true. Families are the most amazing advocates, and even just before all of the endowment and raising money to make sure that not only you're advocating for your child, but everyone else's children as well. So families, raising children with special health care needs spend a lot of their time in, the primary coordinators for their children, and they really are the best advocates for them. You know what your child likes, you know what toys they like, you know what tastes they like, you know what sounds they don't like, you know what might trigger them or make them unhappy. And there's so many things and so many visits and so many things to remember. But the next couple of slides, I want to go through another tool called care mapping that really helps kind of put it all in one place, that allows you to really say, this is who my child is. These are all the people that go into my child's care. So this is care mapping. And care maps, although initially created for families raising children with special health care needs, could really apply to anybody. You could do them for yourself. You could do them for your family members, your aging parents. And it's really a process of putting together a guide that allows you to kind of capture all of the different aspects of care. And it really plays to the strengths. It allows you to include things that are important to your family and your community. It also allows you to create links. So it shows you kind of how all of these things are linked together. And how are they all linked together? Because they're all linked together through the child. And they really put the patient at the center, and then they add in all the peripheral topics. And so when you think about, all the things that go into caring for a child, we have healthcare here in blue, but that's like one spoke of this. We also have, developmental assessments. We have school. We have, advocacy and leadership. We have creation of community. There's the legal and financial components, and then there's the supports that we receive. And when you put it all there, a lot of times it's really a wonderful way to say, wow, I do a lot for my child. This is a visual representation of all that I do. And we hear from a lot of families who say, yeah, it's just what you do, but you do an amazing job. And this is a good way to show others, this is what I'm managing, this is what I do. This is all of who helps me support my child. So how do you kind of start these? They look very intimidating when you look at them as a whole, but they actually start quite simply. You don't need technology. You can do them if you're like a tech person. I am not. If you're a tech person and you want to do this on like Vizio or some other platform that you want to make it look all pretty, but you can start with just pen and paper. And you basically start with a blank piece of paper, and then you start with your child. And outside of your child's circle, you can put your family, you could put siblings. If there's other people that kind of are part of your core community, you can put them there. And then you kind of come in from the center, you just start adding the different aspects of your child's care team. So you could put medical with all the different physicians that your child might see, be it dental, GI, genetics, neurology, physical med and rehab, developmental medicine, ophthalmology, kind of all the specialists that your child may see kind of become part of that medical wheel. And then you might have a separate one for school. Your school one might be, OT, PT, speech. Who's the school nurse that takes care of you? You can add in names if you have a hard time remembering names, or there's so many folks involved, you want to make sure you have their names on there. You can add that as well. And then you may want to continue to add other things. You could add community programs that your child participates in on a weekly or daily basis. You could add your spiritual community that you might go to that might support your child. And you just start to build out this map that takes into account all of the different folks who are in your village. And you can use different colors, you can make it pretty, you can make it all in black and white, whatever works for you. But it's just a wonderful way to have something that really truly represents all of the care that goes into your child. And so coming back to the more complicated one, care maps have been shown to kind of allow you to reflect on your own experience and your own journey by kind of really capturing all of the things that go into caring for your child. Many families, have created their own care maps, say that it gives them a sense of satisfaction and pride to look at kind of all they've been able to do for their child, to see it all in one place, all of the different things that they are managing, makes them feel really proud, and it really helps them assess kind of the big picture. And so, they then can share it with trusted members of their circle. You might give it to the school and say, have I missed anything here? Would you add anything to my school bubble? You might bring it to a healthcare visit and say, should I add anything here? You might show it to a family member. And especially, if people you feel like aren't recognizing all of what you're doing, it's a wonderful way in saying, this is our life. This is all the people who go into supporting my child, and he's the center or she's the center of that. And everybody else who is here is there for that mission. Don't worry about getting it right. You can always draw it again. The most important thing is to just kind of start putting it together, if it's helpful to you. So I've just introduced two kind of very different models. One is more about, the medical, what happens in medical visits, and that's actually what families have often said, is that, care plans really feel like they're medical. They're focused on the medical, they're focused on kind of what's wrong and how do we fix it, versus care maps really seem to focus more on the whole child and really kind of take out of what happens from a medical aspect and really appreciates the entire child. So studies have shown that care plans and care maps, parents often viewed the care plans maybe as a little bit more negative because they were medical and they were all about kind of things we had to do or fix, versus the care maps really felt like they took into account who my child is and gave, while the care plan is the acute management, the care map felt like the management of the child, like everything that went into managing that child. And care maps felt more parent-centered and demonstrated kind of that complex web of what goes into caring for children. So now we're going to pivot a little bit to talk about transitions. I know this has come up a couple of times, even yesterday in our dental discussion. It's a huge challenge, and it's a huge challenge without a one-size-fits-all. It's a huge challenge, too, because there are 750,000 children with special health care needs who will become an adult every year. And so that's a lot of people. And we know there is already a shortage in adult primary care, and that the models in pediatrics and adult medicine are separate. There are also some places where you are housed, as we are a pediatric hospital. And so while we do not transition our patients, particularly those with metabolic disease, our colleagues in other subspecialties do. And so depending on the healthcare environment that your child is cared for, your transition needs might look different. But either way, it's a challenge. One of the big challenges, too, is that there are differences in pediatric and adult care. And I will say, having just read through a lot of literature on transitions and a lot of what's out there and readily available for families, a lot of the transition information is really focused for neurotypical children who have to learn to become their own independent advocate. There is very little out there about how to do this for a child who will remain in your guardianship. And so there's just, even the good transition tools may not be applicable, and that makes it even harder. So when we think about adult and pediatric care, what are some really differences between them? Well, pediatric care is really about growth and development. That's what we talk about. What new skills have we learned? What new things have we done? How are we doing in growth? But adult care is really about well-being and aging. So it's not focusing as much on how do we continue to do these supports? How do we make sure that my child's getting all of the supports that are going to benefit them? It's a very different focus in adult health care. Pediatrics it's designed around caring for families. And so it is shared decision-making with parents. We expect that parents are going to be part of that process to make those decisions. But adult care is really patient-centered. And so the model of adult care is, maybe shared decision-making with a young adult, but that only, happens if the young adult is able to make their own medical decisions. The other challenge is that in adult care, people tend to be a little more hands-off. If you say no to something, you have that autonomy and you can say no. But we know that that's not always the right decision for people. And so it's just a very different way of looking at things. In pediatric care, most pediatric specialty care is kind of located in one space. So you get most of your care from a pediatric hospital. There aren't as many community providers that are subspecialists in pediatric care, but that's totally different in adult care. Because in adult care, you actually have specialists in the community, you have specialists at different community hospitals, you have specialists at tertiary care centers. And so how do you make the decision about which of these providers is going to be best for you? And if they're all spread out now, how do you make sure that that connection that you had when everybody was in one building on one medical record system actually maintained? Often pediatric specialty clinics were kind of close to each other, were close to the auxiliary therapies. Adult care, again, very spread out. Often your referrals might be out into the community or other places who may have even less information. I will also say that in pediatrics, we find lots of folks who don't know about rare disease but really want to learn. In adult medicine, there's a lot of folks who still think rare disease only happens in children. And so, as people are living well into adulthood who have had rare diseases, the just knowledge base of adult medicine hasn't caught up yet. Additionally, pediatrics, you tend to have more time with your doctor. They kind of expect your kids are going to have something to say about things during the visit. They're going to pace for that. They're going to allow for that. We will do visits with people climbing on our laps. We're good with that. Almost, I always say I'm a mom of 4 and nothing flusters me. So if kids are crying, screaming, climbing on me, I'm good to go. If we're on the floor, we're on the floor. That's not really how adult medicine operates. And so you also usually have less time. So there's a rushed feeling to it. I have to get in. I have to kind of say everything I need to say because the doctor kind of has one foot out the door sometimes. So it can be hard to kind of make sure that you feel like you have enough time for your child. And adherence to care, as I talked about, in pediatrics, we often are kind of, how do I make this work for you? Is this, if you can't take the oral medication, could I give it as a shot? If there's, something, if we can't get labs today, okay, we'll get them next week, versus adult medicine is kind of more, this is what we're doing, we expect you to adhere to it, and if you don't, then you have free will. But obviously, if you're dealing with a child who is in their guardianship of their parents, we really like the pediatric model. Medication dosing. Medication is weight-based in childhood. Medication is often not weight-based in adults, which works great if you're like a full-size adult person, but it doesn't work well if you're small. And so, having adult providers who are not giving standard adult dosing, which may be too much for your child. So really often advocating for using pediatric dosing unless you have hit the adult dose. So if you've hit the adult dose, then you use that adult dose. If the dose that your child would get based on their weight is less, then you would use that pediatric dose. And when we think about transitions of care, it's not just healthcare transition. It really is, community resources, guardianship, and what that means. Do you need guardianship for your child? That could be a talk. Guardianship could be a talk all on its own. And really, when I think about guardianship, I often really think about medical decision making. So, if someone, can do a lot, can they give informed consent for medical decisions? Because I think that's a really important one in healthcare when you're thinking about your young adult making medical decisions. I've had families who say, well, my child will listen to what I tell them to do, and they'll say yes if it's a procedure they need. But whether the medical team will take that as informed consent is a very different story, and you don't want to get into a situation where there's delays of care because there's discussions about who can consent for that procedure. Community resources change by age. So there's different community resources for pediatrics as adults. So you may have had teams that you were working with in pediatrics that you have to transition. And housing. If your young adult doesn't live at home anymore, what are the housing options for independent, semi-independent, group home? What is the right housing transition for you? So I won't at all pretend to be an expert on transition. I am a pediatrician. But I will give you a couple tips that I have found helpful. Start early. start thinking about these things when your child is 15 or 16 years old. We don't want to start thinking about these when we're 17 or 18 and that transition is coming, because knowing what specialties you might have to transition away from at 18, which ones are 22, which ones are the most important to your child's care. So can we start thinking about what that transition plan is going to look like for your child's health care? Consider, need for guardianship well before your child is, 18 years old. Is this something that you want? There are different levels of guardianship. There are financial protections. There are different things. Starting to get that information early so that you're making the best decision for your child and yourself, or that you're getting the assessments that you need to actually get guardianship if you need it. And then I often say, with adult care being so scattered in the community, choose a base hospital. It doesn't mean you have to get all of your care there, but identify where you would go in an emergency so that you have that kind of game plan in your mind. And I often think that choosing an adult hospital that is used to complexity, so kind of what we consider our kind of adult counterparts, these big, large academic medical centers, could be a benefit in the case of a surgery, because they're just used to dealing with things that are more complex and sometimes being more thoughtful than a smaller community hospital that is used to doing things that are more run-of-the-mill. But again, this is where it comes back to what matters to you. What matters to you might be proximity to your home and not having to travel to doctor's visits. And you're going to have a lot more choice in the adult world. So we often say, look for satellite sites. A lot of the large academic medical centers, similar to ours in pediatrics, have satellites that might be closer to home. So, Brigham and Women's, which is right next door to us in Boston, has satellites on the South Shore. Mass General has satellites on the North Shore. Picking a center where maybe you can take advantage of those satellite sites for your care, but still be connected within the larger institution. But really thinking about what matters to kind of how you receive care in the adult world, because you will have more choice, except for genetics and metabolism, than you do in pediatrics. So I've introduced, I think, a lot of concepts today around different frameworks for medical care to assist you in, I think, centering the conversations around kind of what you see. So now we're going to talk a little bit about meaning making. And this was the other part of the project that we did. And I realized I never shared that with anybody. So I thought this might be a good audience to think about meaning making, because I think it's also an important thing to bring with you to your healthcare setting, is kind of who your child is and what you have learned and gained from being their parent and being lucky enough to be their parent. And so meaning making really is thinking about kind of what brings joy, what brings emotional, what brings satisfaction in caring for your children. And I wanted to share some of those responses. When we asked families to describe their children who had Smith-Lemli-Opitz, we got, the words we got were, loving, kind, funny, sweet, and I nodded my head because that has always been my experience in caring for these kids. And when we asked, what has having a child taught you, we had a lot of themes that emerged. So appreciating the small things. Parents and caregivers said, because our son is happy and loves to laugh and enjoys the little things, it has helped us to find joy in the small things too. Encouraging strength. So this is one where, sorry, I got to switch my notes because that doesn't have all my notes on it. We found strength. Watching my child do all the things that they do brought us strength, because we really saw kind of what was possible and found joy and strength in kind of those small things that they were able to do. And someone said, "She is my light and my source of strength. I have grown stronger while fighting for her to get what she needs and watching her succeed in all that she has set out to do." People said that they had a changed worldview. He's completely opened our eyes to living each day, each moment, in the moment, taking nothing for granted. Seeing the world through his eyes is a gift. Families talked about creation of community, that we have met and had experiences we never would have had otherwise, introduced to the special needs world, which is now so dear to us. And people talked about bringing families together, like this conference. We work together as a team in our house, and I look at most things as a learning experience. It helps us see the world better. People also talked about sibling empathy, that their siblings having awareness of individuals with special needs had made them more empathetic, had made them kinder, had made them more accepting of the world around them, and that they were also incredible advocates. So creating a new generation of people to advocate. Folks talked about advocacy and being prepared for anything and making sure that they were there to say and to advocate for their child. And understanding and acceptance. Someone said, looks can express more than anything said by mouth. He has made me appreciate each day a little bit more. I try to see people through my son's eyes because he sees no fault and no hate for anyone. And if we could all live in a world like that, it would be a better place. And I think that is really true. So today, we talked about a lot of different frameworks, what matters to you, some care coordination frameworks, some care mapping, transitions, meaning making. And I hope that, when you walk away today, these have sparked maybe an idea or two, something that maybe you could ask your healthcare team to engage with you on, or something that you might want to do yourself. I think it's just so important that medical teams understand you and your child. They are, children are not their diagnosis. They have these amazing, rich, wonderful lives. And if we take the time to spend time with them in that space, we learn so much, and we have better, we are better, we do better, and it makes us all a little bit better. So thank you. Thank you to all the parents and families and patients that I've been fortunate enough to care for. They have taught me so much. And thank you to the Smith-Lemli Foundation, to Lemli-Opitz Foundation for bringing us all together today.
We have time for some questions, if anyone has one. Thank you.
When you were talking about the office visits, how we have to manage so much, I don't know if this would be helpful for anybody else. What we do when we take the module to the doctor, we ask beforehand, is it okay to video the visit because we're discussing so much and he's into everything? We video our visits, so if we need to go back and look at anything or medicine change or anything like that, we can just go back and watch the video.
Yeah, I think that's a great idea because you have a recording. However, I think you have to check with your healthcare settings.
Right,
Some healthcare places won't let you do that, but I do think having that kind of ability to remember and go back when you have time and space sounds like it's really helpful.
And you was talking about guardianship, what my daughter and her husband did with me, because I keep him sometimes to help them out. They went ahead and gave me, because grandparents have no rights in the state of North Carolina, they gave me guardianship, and we split it with him. So if he's with me and something happens, I can get him help. And if he's with them, they can get him help. So we're not doing that back and forth. We can't treat him, so on and so forth. So that might be something else that you might want to think about. You don't lose your child by giving the grandparents guardianship.
Yeah, so I think thinking about kind of who spends a significant amount of time with your child and might need to be able to make those decisions is really, really smart.
I really enjoyed your talk. I really did. The depth, the richness of your talk just really came to the surface. The things that strike me as a parent is advocate, advocate, advocate. Our kids make us stronger too. It seems weird, but our kids, given the love that we put into them, make us stronger. Also, I think the conference in and of itself, having the medical professionals here, we're a family, and I know on several occasions we've reached out when we've needed help, be it to any of the medical people, Dr. Porter as far as getting information, or Audrey Thurm relative to our son's IEP, or concerns relative to our son having a procedure done. and we have a wonderful, supportive community that will support our kids, that will support our families, and I really enjoyed your talk.
Thank you.
So I live in Northern California, and my daughter's getting close to 18, and so we're in the middle of her conservatorship. And I wanted to bring up Dr. Porter's suggestion to make sure that when we're doing the conservatorship, I think you had mentioned something to the fact that when we're doing that, to have the wording in there saying it's okay to participate in research studies, to have that under the conservatorship. Is that, I wanted to clarify that since I'm in the middle of it now.
Every state can be different, so you have to be working through your lawyer. But conservatorship for medical care is different than conservatorship for research in some states. And you want to specify that in there, because if there is a clinical trial that becomes an option, you may or may not be able to have your child participate, depending on what state you're in and how it's initially written.
Thank you for that, Dr. Porter. Any other questions? Thank you very much for your presentation. It was very helpful.